Welcome to On the Edge of Breakthrough, where hope meets innovation in the fight against cancer.
Hi, I'm Dr. Monty Pal. I'm a medical oncologist at City of Hope, and I'm really excited to bring to you On the Edge of Breakthrough, Voices of Cancer Research. We're going to be bringing some of our best researchers to the table to discuss exciting findings from their laboratories, from their research programs, and really get some great perspectives on what their plans are for the future. Welcome back, everyone. It's great to be here today with Dr. Kelly Mahuron, who is leading a very exciting program at City of Hope related to TIL therapy with melanoma. Kelly, welcome to the program today.
Thank you so much for having me.
Oh, great. Well, we're going to dive into TILs in just a moment, but on this podcast, we love to really start at the very beginning of your career, in fact.
Oh, sure. Yeah.
And so I understand you went to UC San Diego for medical school. Is that right?
I did. And I had done a lot of research in cancer previously. And so I was dead set that I was going to be a medical oncologist, actually.
No kidding.
So I went to UC in San Diego, and I did my surgery rotation first just to get it out of the way.
Okay.
And of course, I loved it, to my surprise. So then I was fixated on becoming a surgical oncologist.
And so this cancer research, did that come during your Berkeley days then?
It was when I was at UC Berkeley.
Okay. And what did you do there?
So we were looking at different estrogen receptor pathways that contribute to cancer and breast cancer and other hormone-sensitive cancers.
And is this in labs at Berkeley, or was it at a medical center nearby?
This was Berkeley.
Oh, no kidding.
Yeah.
Oh, that's very interesting. Yeah. So you did that surgical rotation first thing at UC San Diego. Who was it that you worked with over there that really inspired you?
It was really a surgeon named Andrew Lowy, and he does these large cases of peritoneal malignancies. They're huge cases. They take hours, and you can really take out almost every organ in the body, it feels like. But I was just so impressed with how thoughtful he was and how it wasn't just about the surgery. It was really the decisions to do surgery and the complexity of oncology care for surgical oncology.
And indeed, I think you're probably dabbling in what I think is really at a crossroads between surgery and medical oncology with TILs. After UCSD, you went to one of the most storied residency programs in the country at UCSF. So tell me about that and what sort of inspired that choice.
Yes, so I went to UCSF, and as a general surgery resident, it's typical that you spend 2 years in a lab. I had a background in cancer research, but I've always been interested in how the immune system you can harness the immune system to fight cancer. So I joined an immuno-oncology lab, and I actually expanded my training to 3 years while I was there.
Oh, no kidding.
Yeah.
Oh, so that immuno-oncology program up there also is very storied. As a GU medical oncologist, there's folks like Larry Fong and others who, have really sort of shaped a lot of what we know about immunology today. Who did you work with at UCSF?
I worked in the lab of Michael Rosenblum, he's a PhD, MD, and a scientist. And I also worked with Adil Dodd, who is a melanoma medical oncologist.
Oh, no kidding. And you have this terrific paper that I just came across that was published in Cancer Research not long ago with Adil and the gang up there. Can you tell us a little bit about that?
Yes. So I have to begin with the first discovery that we made. So basically in the lab, we were immune profiling metastatic melanoma samples from humans. And the question was, can you predict who's going to respond to PD-1 monotherapy or immunotherapy? And so initially what we did is we profiled all these tumors, and we developed a biomarker assay. And if you look at the frequency of CD8 tumor-infiltrating lymphocytes, or TILs, within a patient sample, and you look at the frequency of these cells that express both PD-1 and CTLA-4, if it meets a certain threshold, the patient has a high probability of responding to the therapy. So the sensitivity of the assay was 80% with a negative predictive value of 100%.
Wow.
It's hard to commercialize, so we didn't really expand it. But basically what we did is we identified a biomarker population. And so it shows you that there's a certain phenotype of CD8 TILs that does predict who's going to respond. So in the paper you're bringing up, we carried this forward and we did single cell and TCR sequencing of these samples from patients. We looked at the cell population, and we found that it's not just a singular population, but really multiple subpopulations, very heterogeneous. So there might be a lot of implications for treatment, and we need to look at these patients' tumors at a closer manner.
Oh, very cool. I can imagine, just getting back to the logistics of this, that it must have been pretty tough. I realize there was some dedicated time to do this research, but balancing the lab, balancing this really intense surgical residency, as I've heard, how did you do it?
I mean, the 3 years were actually completely dedicated in the lab, which was so powerful. And it's really what pushed me to become a surgeon scientist because I love my time so much. It has been challenging to continue doing research and being a surgeon, but I think a lot of what we see in our clinic and the patients we take care of, they really inspire you to continue doing research because you want to find better therapies for these patients.
Yeah, no, that makes a lot of sense. So you wrap up at UCSF and then you come here to City of Hope for your surgical oncology fellowship. Is that right?
Yeah.
What kind of inspired that choice?
It's just an amazing program. You've met a lot of my faculty like Yuman Fong and Lale Maelstrom. And it's a very comprehensive training program where you see all aspects of disease and you come out very well trained. It was my first choice. I was very happy during my time here as a fellow, and I feel very fortunate that they hired me as faculty afterwards.
Oh, yeah.
So,
I have to tell you, I've seen many fellows come through the program over the years. I've been here at City of Hope almost 20 years now. But I will say that, very few actually have the privilege of staying on as faculty. I would imagine, just based on your pedigree, based on your publications, you probably had a choice to go anywhere when it came to a faculty position. What sort of made you think about City of Hope as your landing spot for your faculty years?
to be a successful surgeon scientist, you really have to be embraced and supported by the program. And there's very few places other than City of Hope that really embrace that culture. It's a huge, I would say, it's a huge importance to our chair and to our division chief to have surgeon scientists here. So it's really the people and the support that made this the clear pick to me.
Yeah, I think our audience may have gotten a chance to know Yuman Fong, who's the chair of your department, through one of our previous podcasts. And we probably spent as much time talking about music and archery and other things as compared to medicine itself. But, one of the things that he really emphasized is his focus, his laser focus actually, on making sure that his junior faculty are really well supported. I've certainly seen it as in the GU group. I think one of the things that oftentimes will puzzle patients, and frankly might be a little bit of a mystery to medical oncologists like myself even, is what a surgeon scientist's day looks like. So maybe paint a picture for us. You show up on Monday morning. What's that schedule looking like through Friday?
I think as I go through my career, it will come more predictable. What I thought a surgeon scientist would be one day in clinic, one day in the operating room, and then research all other 3 days. But I have a clinic day, but then the surgeries can be scattered throughout the week and meetings are scattered. You have to be very efficient with your time. You also have to have a very good team that you collaborate with. I don't think anyone can be successful by themselves.
And tell me about that team that you formed around you.
Oh, yes. So Dr. Yuman Fong is one of my direct research mentors. I also work with Stephen Foreman, who you just interviewed, I believe.
Yeah, exactly.
And so he's tremendous. And he is a senior scientist named Anthony Park I also work with.
Oh, very.
So we formed this really nice collaborative team to study TILs and how to improve TIL therapy.
So how does that collaboration work? What do you guys do together?
Our big question is, how do you modify the tumor immune microenvironment with novel therapeutic agents so that you can increase infiltration of TILs so that you can, one, improve efficacy for immunogenic tumors such as melanoma, because you have to, when you harvest TILs for this therapy, the T cells have to be in the tumor, right, to be successful.
Right.
But if you can modify, you can improve outcomes, but maybe you can also expand these therapies to poorly immunogenic cancers such as pancreatic cancer or metastatic colorectal cancer. So where the crossover comes is you have Steve Foreman, who is an expert in cellular therapy and CAR T therapy, and Yuman Fong is an expert of oncolytic virus. So we're actually looking at ways to augment or modify the tumor immune microenvironment with oncolytic virus to increase TIL infiltration.
So help me with the TILs 101, if you will. Kind of walk me through the premise of TILs and what settings currently they're used before we maybe jump into some future horizons for it.
So you're familiar with CAR T therapy, where you can take, blood peripherally from a patient. They genetically engineer those cells, grow them to large numbers, and fuse them back. So in that manner, you have T cells from the blood, but you modify them. So TILs is different because you're just using the native TILs that were already in the tumor sample. It was FDA approved in last year, February 2024, but it was actually discovered or developed in 1980 by Steven Rosenberg at the NCI. So it's not a novel therapy at all.
Yeah, it's funny. Steve Rosenberg has done a lot in the renal cell space, as well as melanoma, of course.
And he's actually a surgeon too. So
it's amazing, isn't it? I think about a lot of these famous NIH researchers, and they have a background in surgery despite running these massive laboratories.
Yeah.
So TILs are indicated for melanoma, but what stage of melanoma? What do patients have to have received in terms of their prior treatments?
So they're indicated for metastatic melanoma patients and unresectable melanoma patients. So you could be localized disease that is not surgically amenable, it's not amenable to surgery. And you have to have progressed on PD-1 therapy of some form. And you also have to have progressed on a BRAF inhibitor if you have the BRAF mutation.
Got it. So, just for our listeners, that the PD-1 inhibition would be drugs like nivolumab or pembrolizumab and so forth. And these targeted therapies would be targeting the BRAF alteration with drugs like MEK.
Yeah,
right?
Combined typically.
What's the patient journey like once they come to your clinic and are interested in TIL therapy?
So usually they're diagnosed, with metastatic melanoma, or they start at an early stage and they progressed. And typically, they've tried one or two or more lines of immunotherapy. So they've had the PD-1 inhibitors, they've had PD-1 CTLA-4 inhibitors combined. Maybe they've also had BRAF inhibitors if they have the mutation, but their disease has continued to progress. So then they meet criteria for TIL therapy. So they'll come in, they'll meet myself, and they'll meet our medical oncologist, who we pair together. We actually have our clinic on the same day, so we see patients at the same time. So, and then we assess them, see if they're a good candidate. I look at their scans to determine what the best lesion would be, or lesions. Sometimes we take more than one. You need to have at least 1.5 centimeters of tissue surgically harvested for TIL. There's so much we are learning on a day-to-day basis because we're learning what sites are better, how much. Does the timing of when the lesion developed impact them? There's a lot of things, changing constantly, and the field is evolving too. But basically, we're looking at them globally and deciding, what the best site would be to use for TIL harvest. And then they schedule surgery with me after they get completely screened. It's a large process, like all cellular therapy. And I do the surgery. It takes about a month for the T cells to grow. The tissue is actually sent out to the company Iovance. And there, the cells are cultured and they're expanded to billions of numbers. And they do not select the TILs at this point. So that's one question too. They're not looking for certain clonotypes of T cells. They're just taking unselected polyclonal product of TILs. And when the product is ready, the patient comes back into the hospital. They get about a week of high-dose lymphodepleting chemotherapy. It's a harsh regimen. Then they get the TIL infusion. And when they get the TIL infusion, they get up to 6 doses of IL-2, which is a cytokine growth factor. So those two elements, the IL-2 and the chemotherapy, also limit this therapy to patients of a certain fitness.
For kidney cancer, for instance, when I started my training, all we had was high-dose interleukin-2. Of course, at much higher doses, I think, than are given in this context for stimulating TILs, but tough therapy.
It makes you feel like you have the flu.
Right. Yeah. Right. The worst flu of your life, I might add. Yeah. Absolutely.
So they're in the hospital when they get it.
Got it.
For all the supportive medications.
Question for you, because you bring up this concept of harvesting sites of tumor surgically. Does it help to have bigger, bulkier tumors in order to get these TILs? Can you extract TILs from, as you'd mentioned, that small threshold of 1.5 centimeters or so?
You can, because it also depends on the viability of the cells. It also depends on the density of the cells. For example, a lymph node probably has more T cells. Sometimes you'll have a giant, exophytic necrotic tumor on the skin. It's actually not a good site to harvest from because a lot of that tissue is necrotic. So there's a lot of considerations. But really, we have a head and neck surgeon. He does our head and neck lesions. We have a thoracic surgeon who will do our lung lesions. I usually do the rest, but you can harvest from almost any spot of the body.
Got it. I just find this whole program so fascinating. It's such a paradigm shift, I'll say. You and I were chatting a little bit ahead of this, and this is sort of a common theme when a new drug or therapy is introduced, right? There's this tendency up front to have patients come in who are what I'd term heavily refractory. They've been on 5, 6, 7 lines of treatment. What can you say about the efficacy of TILs there versus maybe earlier in the lineage of treatment?
I mean, the data is still very early, but I would say TIL was approved based on a phase 2 trial that showed a response in about 1/3 of patients, and a complete response in some of these patients. So it's encouraging. That's why it was FDA approved. But in the real world setting, we are seeing patients that are later stages than they were likely enrolling in these trials. The few lessons we have learned is more tumor burden, more lines of previous therapies. These do overlap with poor responses to therapy.
I mean, I think it's a great call for patients that might be listening to this to maybe consider or ask about TIL therapy a little earlier, sort of in their lineage or pipeline of treatments then perhaps.
Yeah, I've been talking to a lot of medical oncologists too. It's so new. Many people haven't heard of this. But I say if your patients are not, if you see that they're not responding within 2 cycles of therapy, it's a good time to start considering what your next step is going to be. And I would actually recommend referring them just for consideration as soon as a few cycles in and you see you're not responding.
I'll be honest with you. I mean, despite having been in the field for 20 years, I haven't been a part of a process where I'm really sort of introducing for the first time a really sort of distinct class of therapy as you are now, right? This sort of combined surgical and medical oncology approach. So what have you learned so far? What are the approaches that you're taking towards getting the message out there to patients?
I think there's media outreach. I'll give talks to communities, so you can go to patients directly. I talk to other medical oncologists within our network, within the area of Los Angeles. But I think you're right. We need more ways to get the information out there.
Absolutely. I think there's this phenomenon, and I did kind of see this, I guess, when checkpoint inhibitors were just coming out, of a fear factor, right, associated with a novel treatment or technology. And that fear of the unknown sometimes will bind not just the patient, but also the medical oncologist to an older, more antiquated technique.
Yeah, I think, and it is a big therapy. It's a big deal, right? I mean, it's 2 weeks in the hospital. The surgery is often the easiest part, to be completely honest, but it's a big deal. But I do think it's information patients need to know about. And as we're going to continue to learn which patients will be better selected for this therapy, then we can be more targeted, I think, too.
And are there patients where you might say, nope, TILs is not right for you? I'm thinking about distinct sites of metastasis. So for instance, bone metastasis or brain metastasis, right?
That's a great question because that's not the case. So if you have brain metastases, you are still a candidate as long as they can be controlled with radiation.
No kidding. Okay.
Yeah, so that does not disqualify you from this therapy. And then bone metastases, liver metastases, you would think, similar to immunotherapy, you're not going to respond as well if you have liver metastases. The verdict is still out there. And you can actually use liver lesions to extract TILs and have successful treatment too.
Oh, no kidding.
Yeah.
Okay. Oh, that's very interesting.
It's very interesting.
You'd mentioned Steve Foreman, and as you also mentioned, we had him on a prior podcast, and he talked about CAR T-cell therapy, again, shifting gears for a moment, and mentioned that some of the limitations that we have in terms of CAR T-cells are identifying the best target, right?
Yes.
In solid tumors. And also figuring out how to avert the barriers that tumors will often create around them that prevent CAR T-cell activity. Is there sort of a similar phenomenon, maybe not so much with target in the context of TILs, but in terms of overcoming barriers?
Well, the first statement is why TILs work and why we're not using CAR T for melanoma is we don't know what target to target. And currently, so if you think about how the immune system works, and if you look at a tumor, you're going to have multiple different clonotypes of T cells in a tumor. And that means that the tumor might have different mutations. They're expressed differently by antigen-presenting cells, and you have different T cells in that population that recognize different foreign antigens. At this moment, I can't look at a tumor and tell you which T cell is going to be the best for TIL therapy, and I can't pick out the best one and grow only that one. And that's what you want to do with a lot of therapies, really, right? Is know what's the best target to have a good cancer response. But that's why the current product is taking all the T cells and growing them equally. It's a non-selected product because CAR T has a lot of advantages, right? Because you can take it from peripheral blood. You don't need surgery. You don't rely on having intrinsically good T cells. But we just don't know what that target would be.
And this may be overly simplistic, but if I take the research that you did at UCSF, your cancer research paper that you just published as first author, and look at those markers on TILs, right? Could that potentially identify a subset of more viable or active TILs to deliver to patients?
Yes, and that is exactly an area we're focusing on now, because if we can select the strongest the best population for treatment, we could really focus on neoantigen selection is the term we're using. We really select the best, most tumor-reactive cells, and then you could selectively grow those cells to large numbers. You would have a better efficacy.
I mean, it makes a lot of sense to me. Some of the other things that Steve and I dabbled in were ways to really sort of enhance antigen expression, right? So techniques like radiotherapy and so forth. Is there that same literature emerging with TILs as with CAR Ts where you might get maybe a boost from maybe an adjunct radiation treatment?
So actually, radiation is a contraindication for TIL harvest.
No kidding.
Because the site of harvest. Because if you radiate a site you're going to take out surgically, you might have.
That makes sense.
But if radiating in one site and having an ascopal effect distally, which you're suggesting for CAR T, that's an area that needs to be researched.
Okay.
For sure.
Okay.
But that is an area that I am focusing on, is how do you modulate the environment so that you can improve the number of TILs.
And what are some of those things that you're investigating?
So there's different, but the main one we're looking at now is oncolytic virus. For multiple reasons. I know Yuman Fong was on a call and he spoke briefly about it before, correct?
That's right, but I'd love for you to reiterate for the audience.
So oncolytic virus is fascinating because it's very, very safe. It only can replicate in cancer cells. And we haven't found dose-limiting toxicities in humans as much as we have trouble producing enough to give to patients because it's rapidly cleared by the immune system. But the other thing that's so novel about oncolytic virus, so it replicates in the cells, it causes tumor lysis, but it can deliver large transgenes. For example, if there's a cytokine you think will modulate that environment to improve TIL infiltration, it can deliver that cytokine directly into the tumor microenvironment.
So you talked about giving patients IL-2. Maybe you could actually create this, sort of milieu that stimulates IL-2 production in vivo?
Yes.
Okay.
So this is one approach, and there's other approaches of ways to give local cytokines so that you can, don't have to use systemic IL-2. Yes.
That's so interesting.
Yeah.
That's so interesting. I love the pairing with Yuman. He really explained it so well in the sense that we spend so much time with CAR T cells, trying to look for the right target, but very simplistically, it seems as though oncolytic viruses may just sort of provide that target to us, right?
Yes.
Which I think is a brilliant approach.
And I think having more than one target is going to have a more efficient therapy, because that's the problem with CAR T for solid tumors is they get resistant. Because really you need this diverse TCR repertoire of cells that can really target a lot of different clonotypes, a lot of different populations within the cancer cells.
Yeah, absolutely. I would put Yuman in the category of one of the best known surgeons in the country, hands down. Whenever I'm traveling, giving talks here and there and everywhere, it's not unusual for someone to say to me, "Hey, how's Yuman doing?" Clearly he's got this international reputation, but I wanted to talk for a second about mentoring relationships. And we've been doing a lot of that on this podcast. What is that interaction like? How often do you guys sort of meet, discuss ideas? Because clearly you're doing a lot in collaboration.
No, I think it's one of the reasons I wanted to stay at City of Hope, because it's very easy to have people who will sign up to be your mentor and you have your scheduled meetings, but it takes that extra step for people to actively pushing your career forward. And that's what he does. He's always looking for grant opportunities. He could call me at any time, any day. It might be 3 a.m. because he's always traveling for him, right? Okay. He'll say, "Guess where I am?" He's in some different country. But he'll have some crazy, awesome idea. And he's like, "I just thought of this. We need to do a clinical trial on this. Okay, bye. I'll talk to you soon."
Oh, that's cool.
It's just, he always keeps you on your toes, for sure.
I love the way you describe that relationship. So I feel like this term mentor is oftentimes overused, right? He's my mentor, she's my mentor, et cetera. And when you really sort of get into the weeds of it, there's oftentimes very little relationship between mentor and mentee. But this is real. It seems like Human, for many folks on campus, has really sort of taken junior faculty under his wing and working on developing them.
It's very important to him, so he prioritizes it, even though it's not in his direct job description, right?
Yeah.
But I would say he truly endorses his faculty and he wants their success.
That's really cool. Now, we're talking about integration of TIL therapies and so forth. One of the news bulletins that came across my desk recently suggested that now we're able to do cell therapies in Chicago, for instance, which I'm really excited about.
Yeah.
I think that opens up opportunities for patients throughout the City of Hope network. How is that network working out for you? Have you been able to interface with colleagues from Phoenix or Chicago or Atlanta at this point?
It's in early stages, so we've definitely been including them in our tumor boards, and we even have means over our electronic health records where people can message in questions about particular patients because we can look at the charts. But I'm really looking forward to more collaboration on trials and patient care.
And, as I was looking through your publication list, was just very extensive, I might say, for your stage and career. Congratulations on that. I did notice several publications with Gog Singh, who's at the Phoenix site.
Oh, yes.
And so how did you guys get to know one another?
He was here when I was a fellow.
Oh, no kidding.
Yes.
Okay.
And he was great to work with.
Yeah. One of the premises of several papers that I saw was resection of liver metastases in the context of metastatic disease.
Yes.
Did I get that right?
Yes.
So in the context of colon cancer, in the context of neuroendocrine cancer, and just for the audience, it's not intuitive that you would want to resect tumors within the liver if you already have metastatic disease elsewhere at other sites. But it seems as though you've got some really interesting results in doing some analyses of fairly large and extensive public databases.
I think it's just the statement is stage 4 disease doesn't mean the same for all patients. So as you really have to take an individualized approach and understand a patient's disease biology and how they respond to systemic treatments to know what the best path forward. Because there are some patients that where debulking the liver will really give them good survival benefit. Immunotherapy is a particularly interesting one because we actually have demonstrated that if you have liver metastases, your response to immunotherapy is lower.
Right.
And that's been established across different cancers. And in mice models, if you get rid of those tumors, they respond at other sites again.
One of the people that I think has really championed that premise is our head of GI medical oncology, Marwan Faqih.
Yes.
And we still have to get Marwan in this program, but I have an office just down the hall from Marwan, and we've traded notes for over a decade now. And I remember when he's first sort of conceived of this idea of maybe immunotherapy having a differential effect on patients with and without liver mets, and clearly he's carried this forward pretty far in the context of colon cancer. One thing I've got to ask you, and this could still be the subject of future research, is if you take a patient with metastatic colon cancer, right, acknowledging that maybe their response to immunotherapy is going to be poor with liver metastases, if you remove those, could it potentially be better?
It's a very good question. The majority of colon cancers don't respond well to immunotherapy because they're microlite satellite stable, and they're not very immunogenic tumors unless they have certain mutations.
Mm-hmm.
But that is an area where could that change if you take out the liver disease? And we could answer that question at City of Hope because we do resect these patients all the time and they have good outcomes. But I don't think it's standard to resect and then add immunotherapy as a next systemic agent. But it's a very good question. And melanoma, it's starting, with all these great immunotherapies, that's another question. Should we be looking to resect certain patients more? So before immunotherapy, surgery was really the only mainstay for melanoma treatment. And I think people forget how bad the disease was because of how good and better it is now. Mm-hmm. But the response rates to chemotherapy are single digit for melanoma. So prior to immunotherapy, surgery is really the only option. And it has to be fully surgically resected to have any benefit. But now the paradigm switched and surgeons weren't involved as much until TIL therapy for stage 4. But some of these patients have mixed responses, and it makes me wonder if we get these liver tumors out or if we find a way to, treat them, could that reset the whole immune system so that they respond again?
Yeah, I'd love to get an answer to that. And I definitely think that that's an area that Marwan has really been championed and focused on, but could benefit from, I would say, maybe a surgeon's lens.
Yeah, I think we could all work together and do some really exciting research. So
Yeah, absolutely. So if you had a crystal ball, right, and had to sort of project where TIL therapy is going to be maybe in 10 or 15 years, I mean, could you see it being used as an adjuvant? I mean, you think about the complexity of the procedure and so forth. I mean, do you think that it might migrate in that direction ultimately? Adjuvant referring to sort of more of a preventative modality.
I know exactly what you're saying, because interestingly, there has been instances where it is almost being used as adjuvants.
Okay.
And there are patients where unpredictably they may have a response, or they don't have observable tumor anymore, but they have this really good T cell product that we know targets the cancer cells they have, and they probably have circulating cells somewhere. And we also know that when your tumor burden is lowest, that's when you're going to respond the best. So I do think it's going to be where we go eventually. I think we need to make the process smoother. We need to somehow reduce the amount of chemotherapy they need before the infusion, the lymphodepletion, and maybe reduce the IL-2 or eliminate the IL-2 with some different techniques. And then it would be a very well-tolerated therapy.
Got it. Yeah, I'd really be keen on understanding whether something like this could be applied in that setting. And, playing devil's advocate, you worry about something like that lymphodepleting chemotherapy in the adjuvant setting. But on the same note, it is sort of a one and done type of treatment, isn't it?
It is. And, once people recover, there are, sometimes there can be long-term side effects, but the majority of patients don't have that, and they do recover and they're fine within a month or so. But I agree, because if we're doing surgery for patients with localized but really high risk for disease recurrence, those patients might truly benefit from TIL therapy as an adjuvant form, and they're having the tumors resected too. So we have that tissue available.
Yeah, no, brilliant. Okay, you're really kind of getting the wheels turning here for me. And
no, I think about these things too. So yeah,
it's funny for those that are listening. I mean, I think many of the phenomena that happen in melanoma then trickle down into other cancer types, right? So, many of the major developments that you've had in melanoma, checkpoint inhibitors and so forth, it takes a little while, but ultimately it'll find its way to renal cell, then to lung cancer and breast cancer and other perhaps less immunogenic disease types. But maybe that's a good place for us to segue into some conversation around getting outside of melanoma with TILs. I mean, do you project that, with your crystal ball again, that TILs might be something we're using in pancreas cancer or lung cancer?
I think we will. So there are clinical trials with, very select patient groups, especially coming out of the NCI. One was recently published, and they're looking at these other solid tumors. Now, because these tumors are really poorly immunogenic and they don't have a lot of tumor-reactive TILs to begin with, you can't just do this non-selected approach where you culture them and expect something good to grow. So in those patients, they are really selecting out the neoantigen reactive cells. The process takes longer.
Okay.
So that's something to consider. And the trial data, it's still early, and it was safe, but there's a lot of work to be done in that area. But I think in the future, we'll just have better ways of selecting the right T cells, modulating the environment before you harvest to increase the number of T cells. And then this therapy could be expanded to a lot of different groups.
Fascinating. I can't wait to sort of see that incorporated in some of these very sort of challenging to treat solid tumors.
Oh, absolutely. We really want to expand it to all cancer types is our goal.
I swung by your office one day and we were having a brief conversation around this, and I thought it was actually more of a pipe dream, to be honest with you, when you told me, but then I went to the literature and saw that, no, there's a fair amount of investigation underway, just as you've mentioned, and looking at TILs across the spectrum.
There's a lot of excitement around this area for different cancer types.
Yeah.
And you have to be optimistic, right, when you're in research, so.
Well said. Yeah. So I did want to sort of segue into a different conversation with you, and something that we've chatted with everyone around here is balance. I mean, you do so much, but in particular, as a surgeon scientist, I'll start with my role as a medical oncologist. I've got clinics and I've got research, but you've got clinics, research, and then the operating room, all three of which I think are incredibly taxing and vexing. How do you kind of hold it all together? What's your release? How do you maintain that balance in terms of, mental health and emotional health in this career?
I think if you go into this career, you just really need to love it. And since starting my practice, I've realized how much I love this job because you get to interact with people. And to be honest, it's a hard job. And you do see some very heartbreaking things because I see a lot, because I, as a surgeon, see a lot of stage 4 patients with the TIL therapy. It's not just the early stage that some surgeons may see. But you're really able to be there for people when they need you, and you develop really special relationships. That's the other thing that really drew me to surgical oncology is it's not just an operation and you're done. Like, these are your patients for a very, very long time.
And are you like human? Do you have these pursuits outside of medicine that you really love, like music or sport or whatever?
I love everything. I have a nearly 2-year-old toddler at home, and so I'm busy outside of the hospital too. But I think it's just all about balance and not being too worried about separating everything. That's also my advice, because if you're always worried about having this time is totally protected, it's hard not to have things bleed over. You just have to find a way for it all to work together.
That is such a great philosophy. I'm glad you said that, because I think that in an academic career, right, you do want to compartmentalize, right? There's that pressure to say, okay, this is going to be my research day or this is going to be my clinic day. But just as you said, sometimes if that patient rolls in, you got to see them right away. You know, if that grant opportunity comes up, you got to write it, right?
You do. And I think, you just have to be a little flexible at all times, and having a supportive bosses, supportive family, it just makes a big difference.
I bring this up because I think this is such a vexing time for academic medicine, particularly for not just any surgeon scientist, but a clinician scientist in general, right? Grant opportunities are drying up a little bit. Career prospects may seem a little bit grim. What do you say to that medical student or undergraduate, who's thinking about a career in medicine these days? What is your advice to them?
I mean, I think it's always easy to worry about the future, right? Because there's not a lot of surgeon scientist job because, a lot of institutions, that's not their priority. You can get a great grant, but what if the grant funding gets pulled? You just don't know. But you can't live that way because it's not beneficial to anyone. All you can do is do your best and do what you love and just see. And I will say, if one door closes, usually you can find alternative approaches.
Yeah, I do think that certainly, as a physician scientist, there's that opportunity to maybe shapeshift a little bit too, right?
Yes, absolutely.
Things are going well on the research front, focus more on that. If things are going well clinically, focus on that, and, maybe pick up multiple pursuits. You're doing TIL-based research, but you also have this great outcomes research related to liver resection, right? And I think that by wearing sort of multiple hats and having that diversity and focus, right, you kind of protect yourself a little bit. Would you agree?
I agree. I think it's good to be a little broad without spreading yourself thin. I'm not exactly sure how to do that yet.
Yeah.
But I agree. You don't want to have all of your ambitions in one place because you can't predict the future and something may not work out. But I also think it adds a lot of variety and it's more fun to be on different projects. And that clinical aspect really gives balance to your research too.
I have to agree. One thing we're asking everyone who comes on this podcast, and this is a tough one. If you look at the title of this podcast, it's On the Edge of Breakthrough. Right. What does that mean to you?
I think it's what I really love about City of Hope is you're at a place that offers these top-notch, leading-edge technologies, right? But at the same time, we're not stopping there. We're constantly pushing the field because you can have something that works, but it doesn't work for every patient. So every time I have something saying, oh, this is good, but could it be better? And you're just like constantly pushing different directions to see how you can get the field to advance.
That might be the best answer I've gotten to that question. Thank you for that. That was really great, Kelly. Well, I can't tell you what a pleasure it was to spend some time with you today. I've been so intrigued by your body of work. Thank you for bringing this phenomenal TIL program to City of Hope. And
yeah, thank you so much for having me. This is very fun.
We've got to do this again, okay?
Yes.
All right, thanks.
This podcast was produced in partnership with Amaze Media Labs.